The broadcast is now starting. All attendees are in listen-only mode.
Greetings, I'm Dr. Deborah Fennell. It's my pleasure to welcome you to this webinar series. This series focuses on the use of opioid therapies for treatment of opioid dependence and on the safe use of opioids in the treatment of chronic pain. This series is one of the many resources made available by the Prescribers Clinical Support System, Opioid Therapies, a program that is funded by the Federal Center for Substance Abuse Treatment and operated collaboratively by 6 other partner organizations. These include the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and the American Society for Pain Management Nursing. Just a few quick housekeeping notes before we get to today's presentation. In the upper right side of your computer screen, you will see a control panel. In the lower portion of that panel, you can type in a question or comment and submit it to the webinar organizers. You can do this at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. If we are unable to get to all your questions in the allotted time, our presenters have agreed to respond to them in writing. The webinar, presentation slides, and the questions and answers will be posted on the website in the near future. This will be on the PCSSO website as well as the INSA website. That latter website is www.intnsa.org. So today, Drs. Deborah Gordon and Judith Pace will address safe use of opioids in hospitals. They will describe the common causes for adverse events associated with opioid use in hospitals, outline evidence-based actions and a systems approach to avoid opioid-related adverse events, and discuss management of acute pain in patients with substance use disorder. Our first presenter today is Dr. Gordon. Dr. Gordon is a teaching associate with the Department of Anesthesiology and Pain Medicine at the University of Washington, Seattle. She works in conjunction with the inpatient and outpatient pain relief services, clinics, and hospital staff to collaborate on improving systems of care and designing outcome evaluations that benefit patients and populations across the continuum of care. She is a member of the executive team for the John A. Lozer's NIH Designated Center of Excellence in Pain Education. Dr. Gordon has also been involved in a number of national and international projects focusing on improving pain management, including the American Pain Society's Quality Improvement Guidelines. Our second presenter for today is Dr. Judith Pace. Dr. Pace is the director of the Cancer Pain Program in the Division of Hematology Oncology and a research professor of medicine, Northwestern University, Feinberg School of Medicine. Dr. Pace has served as president of the American Pain Society and secretary of the International Association for the Study of Pain. She has traveled widely internationally to educate healthcare professionals regarding cancer pain relief and palliative care. Dr. Pace serves on the editorial board of the Journal of Pain, the Clinical Journal of Pain, and the Journal of Pain and Symptom Management. She is also the author of more than 150 scientific manuscripts. With this, I want to turn it over to Dr. Gordon to begin today's presentation. Dr. Gordon?
Thanks, Deb, for the kind introduction, and thanks to all for hosting this really important topic. I know it's certainly an area of increased attention throughout the country and a challenge to all of us, regardless of our care settings or our patient population. We certainly want to also thank SAMHSA for the grant that's underwriting this webinar series. And again, Deb gave you the objectives, so I won't repeat them here, but they're there again for your review if you'd like them. So I'd like to start my piece of the presentation with a case study because I think it's always good to, as I'm going through some of the bullet points, think back about how this really applies to a patient situation, whether it's this patient or a patient that you may have cared for recently. So this is not too atypical, really, in this day and age. This is a 56-year-old, 280-pound male on methadone maintenance, 80 milligrams daily for a remote history of polysubstance abuse, including opioids, specifically the long-acting oxycodone, which is a common opioid used for perioperative pain management. He's now scheduled to undergo a lumbar surgery in about a month for back pain with radiculopathy. He's got a lot of anxiety about his pain postoperatively, and he's requesting benzodiazepines perioperatively. So think back about how you might provide a plan of care for a patient like this. What would we do before his operation? What would we do in the acute few hours to days? And then how would we transition him to the outpatient setting again? What are the risks of opioid safety for a patient like this in the hospital? And then, again, what are realistic goals in terms of pain management? You may all have seen the recent Joint Commission Sentinel event alert. If you haven't, it's very easy to just do a quick internet search for it. For those of you who aren't real familiar with the Joint Commission Sentinel event database, this is a collection of adverse events in hospitals that have resulted in either permanent harm or death. And of course, unfortunately, opioids are always in the top 3 categories of drugs. Looking at opioid sentinel events that have occurred in this country, the Joint Commission was able to kind of boil down and look at these 3 root causes, if you will, of those events occurring. And that includes lack of knowledge of providers about the differences and potencies of the commonly used opioids. It has to do also with improper prescribing and administration of multiple opioids at the same time, or multiple modes of administration, for example, using oral and parenteral together, or using transdermal patches for acute pain, and inadequate monitoring of patients on opioids. So what are the characteristics of patients that are at risk for respiratory depression? There's a long list, and again, it's listed in this Joint Commission Sentinel Event Alert. It's patients that require increased opioids, so you have both extremes of patients who are opioid tolerant or need large doses, as well as the opiate naive. Patients who have a longer length of time receiving general anesthetics. Patients who are receiving other drugs that depress the central nervous system, including benzodiazepines, even antihistamines like diphenhydramine or Benadryl. Certainly the lots of other drugs around the operation are used that can depress the central nervous system. Patients who have pre-existing pulmonary or cardiac disease or end organ dysfunction like renal and kidney disease, liver and kidney disease. Patients who have obstructive apnea. People have large incisions, so there's large abdominal or thoracic surgeons. And certainly our patient is having a spine operation, which might not necessarily affect the diaphragm and breathing so much, but may be very painful to take deep breaths or to move around. Patients who are older age, you'll see there's a rapidly increased risk when they're exposed to opioids, respiratory depression, and people who smoke. So I think if you look back to that patient I presented, you can see there's probably several risk factors that this gentleman poses when he comes to the hospital. This is just a quick comparison of some of the commonly used IV opioids in hospitals to kind of show the differences. We know that all opioids have about the same effect, provide the same level of pain relief, but their potency is different, so we have to use different doses because of the receptor affinities. So for example, we use micrograms of fentanyl as opposed to milligrams of morphine to get a similar effect. I think what's most telling is kind of the differences in those doses. So if you look at those 2 green lines below, 200 micrograms or 0.2 milligrams of IV hydromorphone, which is dilaudid, is a very common starting dose for PCA or even for a small bolus dose to an opiate-naive patient. And that's approximately equal to giving 1.3 milligrams of IV morphine. But often in hospitals, there can be human error in programming or staff not understanding that 0.2 is not the same as 2 milligrams, because 2 milligrams might be a common dose of morphine given, and if you see 2 milligrams of IV hydromorphone, it's approximately equal to somewhere in the neighborhood of 13 to maybe 15 milligrams of IV morphine. So you can see there can be a very opportunity for confusion and risk and overdosage of drugs. What is the definition of respiratory depression? I think most of us heard and learned long ago that it's a decrease in the respiratory rate. Most definitions put it at less than 8 to 12 breaths per minute. But it's really a very vicious cycle and a very complicated cycle, too. You get a progressive rise in CO2 and a fall in your O2 saturation. You see a lower carbon dioxide drive and a blunting of the chemoreceptor responses to both oxygen and CO2. What you might see often is someone who maintains an adequate respiratory rate, but they have very poor quality of respiration. They have this prolonged exhalation phase. You know, it ends up suppressing respirations, and the end result is kind of this impaired gas exchange. And providing supplemental oxygen can sometimes mask problems. Certainly in patients with COPD, it can cause further increases in CO2 retention. So it's really something that qualitatively we have to look at more than respiratory rate. And I hope most of you understand this, but we know that sedation is really the most important predictor of respiratory depression in patients receiving IV opioids. And there have been some studies, including this one, that showed that, you know, almost a quarter of physicians, pharmacists, and nurses were not really aware of that fact. Here are some of the other common drugs used in a hospital setting that may compound the risk of respiratory depression. Certainly with this gentleman, giving benzodiazepines could be particularly risky, although with high anxiety, you know, we have to do some management of that to help him get through this. Muscle relaxants can be particularly problematic. You'll notice at the bottom it says gabapentin, pregabalin, gabapentin, gabapentinoids have some risk of sedation, but I do think it's important to point out that the sedation that you'll see with gabapentin and pregabalin has never been linked to respiratory depression. So it's really these drugs above it, like the antiemetics and the benzodiazepines and antihistamines, muscle relaxants, that are really the most problematic. So the Joint Commission and the ISMP, which is the Institute for Safe Medication Practices, recommends that we all have a systematic approach to safety in organizations, and that includes having effective processes, utilizing safe technology, appropriately educating and training all staff involved in this, and then using validated and effective tools. So I'm just going to run through some of that really quickly. It's important that we have policies that really specify clearly safe and appropriate monitoring, particularly this issue of serial assessments. It's really important that when nurses assess a patient for respiratory depression, that they do that before they rouse the patient. So you really go into the room, observe the patient for a minute for their respiratory rate and the quality of their respirations, and to look at how easily they rouse and look at serial sedation. It's important that we reinforce teaching with families and visitors to not assist patients with IV PCA. IV PCA with proxy has been linked to a number of deaths because of accidental overdose. That we use pulse oximetry and capnography carefully in carefully selected patients. When used, those technologies should probably be used on a more continuous basis rather than the spot checking basis, which you can catch gaps and miss problems when they're developing. It's also important that we have additional resources or triage pathways in hospitals for second-level review by specialists for some of these complicated cases that are high risk, especially if you're using drugs like methadone and fentanyl that some staff may be not too familiar with and understanding. You know, there is sometimes a narrow margin of safety there. It's important that organizations track and analyze opioid-related events for quality improvement purposes. And I think, you know, most organizations will look at naloxone use. Naloxone is, I think, a tricky indicator. You know, across hospitals, it's going to be probably less than 1%, maybe 1 to 2% of patients in a hospital will require naloxone. That doesn't necessarily mean there was something wrong. you treat 1,000 patients, you're going to have one patient who's going to probably have significant respiratory depression. But it's important to really look at those events to understand, are there other things happening, like, people giving different routes together and, inappropriate monitoring. I think it's really important that we utilize safe technology. We have these electronic medical records and wireless smart pumps, and I think that there's real opportunity here for us to have these systems help providers give safer care. So we need to develop and build in red flags and alerts that are not going to exhaust people with alarming every 2 seconds, but give them appropriate feedback. You need to separate look-alike, sound-alike opioids and use tall man lettering. You've probably all heard of situations where people grab hydromorphone instead of morphine because they see the morph. So separate those drugs. There are conversion support systems to help do equianalgesic dosing calculations or translating, oral to IV routes. Although certainly that's more complicated than just doing a math, and I would caution not to rely on calculators to do this kind of work. And then certainly PCA can help reduce the risk of oversedation, because when a patient becomes sedated, they will quit pressing their button. It's very important that we do appropriate education and training of our providers, and that includes both pharmacologic and non-pharmacologic strategies. Again, people need to understand how best to assess for sedation and respiratory depression, and understand the difference between ventilation and oxygenation. And I think, this issue of engaging patients in their care so that they understand safety and appropriate goal setting and how to safely use and taper their opioids when they're discharged. So just like we do a lot of education preoperatively in a hospital or on admission, we need to do that when patients are leaving the hospital as well. Dr. Pace is going to talk a little about some of the screening for opioid misuse. I think many on this call are probably familiar with some of that, as well as some of the validated and standard tools for monitoring for respiratory depression. I won't go into those at great detail, but you can see these are the very commonly used tools that have been validated in a number of populations. So just kind of summarizing some of the factors to avoid accidental opioid overdose. Again, we want to screen patients for risks for respiratory depression. So when we have a high-risk patient, we can keep a closer eye and individualize the monitoring for that patient. We want to understand their potential for tolerance or intolerance of different opioids. It's recommended that we do a full body skin assessment on admission to check for fentanyl patches or other implanted delivery devices, so we understand what patients are receiving. We have to take extra precaution when patients are receiving those other CNS depressants. I've talked about having some triage or availability for pharmacy or pain specialists consultation when you have complex situations or making big conversions. We always want to avoid rapid dose escalations, even in opioid-tolerant patients. Take extra precautions at time of handoff. And really importantly, I think the mantra, even in chronic pain and acute pain in palliative care, is use a multimodal approach. If all we do is use an opioid, I think we're going to fail for that patient. So by a multimodal approach, I'm talking about combining strategies and different drugs with different mechanisms of action that can produce a superior level of pain control and often provide kind of an opioid-sparing effect. So you don't have to use such high doses of every drug, because the drugs together will provide, somewhat of a synergistic effect, if you will. Here are some of the benefits that have been shown for multimodal analgesia. As mentioned, improved pain relief with reduced side effects and opioid-sparing effect. You get continuous coverage with less gaps at time of end-of-dose failure. And really, they've been able to show that multimodal analgesia can enhance recovery and outcomes for patients. Certainly not all patients are eligible for all of these strategies. They can be somewhat labor-intensive, but I think carefully chosen, they can really improve the quality and safety of care. When patients have a history or active addiction disorder and they're in the hospital, the same principles apply as I think they do to outpatient, and that is really clear communication, having a single prescriber who can respect the patient's tolerance and have empathy for the situation, can reassure the patient that we're going to manage their pain the best that we can. Whenever possible, we try and avoid the use of short-acting IV PRN formulations and use the oral route. When prolonged Preneral is needed, we will recommend the use of IV PCA as being very appropriate. And again, exploring non-opioid alternatives, regional, but I think this issue of communication and trust is critical and essential to success. So if you go back to that patient that I started with, who's having that lumbar surgery, this may be the type of analgesic plan that we would consider, and that is the morning of surgery preoperatively, we would give a number of medications, including his regular methadone dose, which we would continue through the hospitalization. There's really very little evidence, even in patients who are not on maintenance therapy but are just on chronic opioid therapy, that there's really little benefit in trying to taper their medicines or not give them their chronic opioids prior to operation. So we're going to use drugs like ketamine intraoperatively and maybe postoperatively. We're going to get to the oral route as soon as possible with a slightly higher range than we would use in an opiate-naive patient, but again, having a clear plan for discharge. So with that, I think I'll turn it over to Dr. Pace, and she'll give you some additional cases.
Hi, thank you so much, Deb. That was really excellent, and Deb shared some really immeasurably important information about opioid safety. What I'd like to do is to extend the discussion to talk more about the issues of substance use and some of the misunderstandings that can occur regarding this particular topic, but at the same time acknowledging how essential it is that we understand this topic quite well, given safe prescribing and safe delivery of pain medication. So I'm going to just whet your appetite with 3 cases, and I suspect they'll probably generate some smiles or some thoughts about folks that you've cared for in the past. The first case is a 34-year-old Iraqi war veteran who was recently diagnosed with ALL leukemia, and he's hospitalized for neutropenia and increased pain. He has graft versus host disease after a stem cell transplant with skin, respiratory, and GI involvement. These are some really serious complications that we see after transplant. When hospitalized, he's been hospitalized numerous times because neutropenia is a problem. He asks for IV hydromorphone, despite the fact that he can swallow. He asks the nurse to give it in the closest port and to inject it rapidly. And he also requests diphenhydramine to reduce pruritus, or at least that's what he describes the purpose of the diphenhydramine is for. So let's put that patient aside for a moment and look at another patient, a 63-year-old engineer undergoing chemoradiation for head and neck cancer. This man's hospitalized for pain and placement of a G-tube. And for those of you who work in oncology or who have cared for people with cancer, you know this is one of the most painful regimen that we employ. People get really awful mucositis. And I'm going to apologize, for my examples being more oncology-oriented, but honestly, cancer patients are seen by everybody in the hospital, so it behooves us to all be somewhat facile with the care. Furthermore, these examples could be easily extrapolated to other diagnoses. This gentleman is getting morphine 10 milligrams IV every 2 hours and is reporting that it's not effective in relieving his pain, and no sedation is observed, which is interesting because we would have thought that he would have probably gotten a little bit of sedation given that he hadn't really been taking very many opioids that we had prescribed. An increase to 15 milligrams provides little additional relief, and he demands additional increases. And then the last case is an 82-year-old artist with a known history of colorectal cancer presenting to the hospital for confusion. He's been taking the morphine extended release 60 milligrams every 12 hours, as well as morphine immediate release 15 milligrams every 3 hours around the clock for the visceral pain associated with his cancer. So just to kind of, as I said, whet your appetite a little bit, let's move on, and we'll come back to those cases at the very end. So one of the most difficult aspects in our care is identifying when is behavior aberrant associated with addiction, or when is it aberrant associated with other factors, and what might those other factors be. I get asked to see quite a few patients where the clinician says, I think there might be an addiction problem. And when I ask, well, tell me what are those cues, they'll say, well, the patient calls a lot for refills. And then I'll look at the refill history, and they've been given 30 tablets, 30 tablets, 30 tablets. So it's not so much that the patient was exhibiting behaviors of addiction, but rather they weren't getting adequate analgesia. And that's been labeled pseudo-addiction, where the patient isn't getting an appropriate regimen for pain, and so they keep asking for more. Other factors that can contribute to these aberrant seeming behaviors are psychiatric disorders. Chemical coping is very common, where individuals feel something and they have very little coping strategies other than taking a pill. We see mood disorders, and initially opioids do help treat anxiety or depression or sleeplessness, another problem that we see in patients with complex medical problems. But we know that tolerance quickly develops to those effects, and the patients no longer get relief of anxiety, depression, or sleep. I had a patient once referred to me who had advanced lung cancer, and she had no pain during the daytime, but took 20 tablets of hydromorphone or Dilaudid during the night. My first question is, was your bed comfortable? And she laughed and said, oh yeah, it's great. And my second comment was, the night times are very frightening, aren't they? And she immediately started to cry. So hydromorphone initially helped soothe the anxiety and the sleeplessness that she was experiencing at the nighttime. And this is very common. The nighttime has very few distractions. And people wake. They think about all those existential questions. What's going to happen to me? The opioid initially helps, but then it doesn't over time. Some people have encephalopathy. They can't follow an analgesic regimen, much less any other medication regimen. Some people have borderline personality disorders, and they're using the medications to self-manage their personality disorders or their mental illness. Some patients clearly have low literacy, and they just aren't able to follow a treatment plan. And then there are those individuals who have criminal intent. I think a very helpful model for caring for people with pain, particularly people with chronic pain, whether it's from cancer or non-cancer causes, is the biopsychosocial model. Look at the patient. Deb's given us a great perspective of the biologic and how we might treat different aspects of that pain pathway. But it's also important to look at anxiety, anger, depression, sleep disorders, and other psychological factors that can contribute to pain. Pain contributes to those psychological factors, and it becomes a downward spiral. And then particularly in today's era, things like lack of support, financial limitations, and then a pre-existing history of substance abuse, either the patients or their caregivers, really complicates this entire picture of pain management. So Deb introduced for us some of the issues related to treating individuals with opioid abuse, and how do we manage pain in people with this complex comorbidity. Well, first we have to do a very thorough assessment, both of their pain as well as risk factors for abuse. And I'm going to share with you a few of the tools that can be used. And then an important recommendation is the use of universal precautions. And that may include agreements, which some people have called contracts, but there's been some discussion in the literature that the use of the word contracts implies some sort of legal agreement, and that actually this is more of an educational document or an agreement between prescribers and patients. And so maybe a better use of is the word agreement. Urine toxicology is very important, and that's a whole webinar in and of itself regarding how one does that screening and how one interprets some of the more sophisticated toxicology reports. Thank goodness for the use of prescription monitoring programs. And I know that some individuals have looked at these as being sort of a punitive sort of tool to help us, quote unquote, catch people. But actually, I have many patients come to see me in the clinic who aren't really exactly sure what they're taking. And when they come to me and say, I'm on that little blue pill, I think, you mean Viagra? I can look at the prescription monitoring program. And in Illinois, where I practice, thank goodness we've got an excellent program. We can identify the drug, the numbers of tablets dispensed, the dosing, where they picked it up, from which pharmacy, how it was paid for, who was the prescriber, and all of that information is exquisitely important from a safety perspective as we're prescribing these medications. And then when patients are admitted to the hospital, to ensure that we continue with safe prescribing. And then education, and I believe nurses are core to this. We have been trained to educate patients, and we can do so in terms of safe taking of these medicines, safe handling, safe disposal. So here are a few of the tools that are available, and quite honestly, in all of the evidence-based guidelines sort of reviews of the different tools, there isn't one tool that comes out better than another in terms of assessing for risk. So this is the opioid risk tool that was developed by Lynn Webster. It's almost 10 years old now. And basically it looks at family history, personal history, age we know is a risk factor and that younger individuals are more likely to use opioids, psychological disease, and importantly, history of pre-adolescent sexual abuse. That comes out over and over and over again as a leading risk factor for substance abuse. The family history of substance abuse can be an environmental factor in terms of if the patient's living in an environment where people are often using or misusing alcohol, prescription drugs, illegal drugs. That certainly places them at risk. It's also a bit of a proxy for the individual's genetic predisposition to abuse. The CAGE is an old tool that primarily looked at drinking or alcohol use and has been modified to also include drug use. So have you ever felt you ought to cut down on your drinking or drug use? Have people annoyed you by criticizing your drinking or drug use? Have you ever felt bad or guilty about your drinking or drug use? And have you ever had a drink or used drugs first thing in the morning to steady your nerves or to get rid of a hangover? So these are some of the questions that individuals have found helpful. And again, you might be wondering, why is someone who works in oncology doing this presentation today? Well, there are some good data that even people with cancer, and maybe even especially people with cancer, are at risk for substance abuse and alcohol use. It might be what has led to some of the development of their cancer. And Eduardo Barrera at MD Anderson has done probably the most work in the cancer population, looking at the CAGE, looking at the prevalence of alcohol use and drug use, and then predicting who is more likely to still be on opioids for a long period of time. And there are very strong predictors. Here's another tool. It's a bit longer. This is used more in the VA system, the Addiction Behaviors Checklist. And this one is coded by the practitioners. So has the patient used illicit drugs? Have they hoarded meds? Have they used more narcotic than prescribed? Did they run out early, etc.? Now, a little caveat. Did they run out early? Check your prescription monitoring. Did the pharmacy, because of shortages, dispense a smaller amount than was ordered? So before accusations are made or conversations are had with the patient, be sure you have all the data. So why is all of this important? You all know more than most groups that this problem of drug overdose has really escalated in the past few decades. And I think all of the attention paid to Philip Seymour Hoffman's death just this past few weeks is making the public more aware of the extreme importance of these data and this problem. These data are from the CDC, so the Centers for Disease Control are really keeping a pulse on the problem of overdose related to drug use. And when we see one death, that's just the tip of the iceberg. For every death, there's 10 admissions for abuse. There's 32 emergency department visits. There are 130 people who abuse the drugs or are dependent on these drugs. And there are probably over 800 people who are non-medical users of these drugs. So for every death, there are quite a few other people who are affected by this problem. Here are some more data, again, from the CDC. 15,000 people die every year of overdoses involving prescription painkillers. 1 in 20 people report using prescription painkillers for non-medical reasons in the past year. And in 1 month, enough prescription painkillers were prescribed in 1 month in 2010 to medicate every adult American around the clock for a 1 month time period. So an amazing array of statistics here. Now some people say, well, as a culture, we're just more addiction prone, and all drugs, prescription drugs as well as non-prescription drugs, are increasing. Now these data are a little bit older. They stopped 7 years ago. I think we would see a blip recently with heroin. But overall, we don't see that much of an increase. Now, we do see a huge increase in overdose deaths associated with opioid analgesics, in other words, prescription drugs. And many argue that the increased rates of heroin use that we've been seeing in the last year is because people started using prescription drugs and then could no longer obtain those drugs and found that heroin was cheaper. So there is a much debate in the addiction world and in the pain world about the sudden spike in heroin use and whether it might be attributed to prescription drug use. This also is a problem amongst women in particular. And what we see is prescription painkiller overdose deaths just escalating amongst women. So this graph just represents use amongst women, and you can see opioids are really breaking away from the pack of the other drugs like antidepressants, benzodiazepines, cocaine, and heroin. Very interesting article that I just read in a recent issue of the journal called Pain, looking at people who have a history of abuse and looking at who uses oxycodone and who uses hydrocodone. And interestingly, oxycodone was more likely to be used and liked, if you will, by younger male individuals who are more likely to be risk takers, whereas hydrocodone was more likely to be abused and used, liked by women, older women, people who were less likely to be risk takers. So interesting even how the different drugs diverge. And these data come from the National Household Survey, which is a survey of 12th graders, so people who are in their senior year of high school, looking at their past, within the past year, their use of prescription and over-the-counter medications. And you can see marijuana is the most likely abused agent, but as you look at the red bars, we see Vicodin, which is hydrocodone, Adderall. In fact, recent statistics suggest that about 25% of all college students have used Adderall without a prescription. Salvia is a modified version of marijuana or THC. Tranquilizers, cough medicines, these often contain codeine, OxyContin down towards the end there. So very common for high school students in their final year of high school to have used non-medical prescription drugs. Now, where are people getting these? And this is something that's important for us as nurses to be able to communicate to patients. When I see patients in the clinic, every first visit that I spend with patients, we talk about safe storage and safe disposal, and it's fascinating to me, despite all the information in the media about celebrity abuse of drugs, about people losing their medicines, most of the public are shocked that this is even an issue, that most people get their drugs from a friend or a relative, that patients can have the risk of having their medicine stolen. And just a year ago, after the Super Bowl, one of my patients came to me very sheepishly and she said, "Judy, I know you told me not to leave my medicines in the medicine cabinet, but I had a Super Bowl party. It was only my family. They were only supposed to use the powder room, not my bathroom. And at the end of the night, half of her OxyContin were gone." So now she's in trouble because insurance won't pay for an early refill, and now she also knows that someone in her family has addictive disease. Now, I'm not asking for any of us to be law enforcement officers. Our job is to treat pain and other symptoms, but we do need to avoid contributing to diversion, just like we don't want law enforcement to interfere with our care. So it's important that we communicate to patients the sources of diversion, and the second most common source in the studies that have been conducted appear to be from medicine cabinets. So we need to let patients know how to store their drugs safely. So I educate patients that they shouldn't leave their medicines out. They should store them in locked boxes, that when the drugs are no longer needed, they should be dispensed to take-back programs. The DEA offers a national take-back program twice a year in April and in October. Those dates and locations can be found on the web. Some pharmacies will take them back, but most will not take back Schedule II opioids. And many police departments will take them back. In Chicago, there are about 6 police stations that will take them back. This was a combined effort of the law enforcement as well as our local environmental programs, and they incinerate the products. The purpose is to keep people from putting them down the toilet. Unfortunately, the DEA and the FDA don't agree on how safe disposal should occur. The FDA still suggests, for example, that fentanyl patches be flushed down the toilet, whereas other organizations suggest that they can be mixed in wet coffee or kitty litter and then disposed in the garbage once they form kind of a slush. So let's go back to our 3 patients. This 34-year-old Iraq War veteran that we talked about earlier with leukemia asks for his IV hydromorphone to be injected quickly in the closest port, and he also asks for diphenhydramine. Upon closer assessment, this gentleman has extreme anxiety and even has PTSD that was reactivated with hospitalization and with the diagnosis with a potentially life-threatening illness. We got him very strong psychological support, psychiatric support to both pharmacologically and non-pharmacologically manage his mood disorders, and explained that the hydromorphone and the diphenhydramine are not the appropriate agents to treat his emotions. We required that he take analgesics orally, and through a team effort, we were able to help him understand that he was treating these emotional concerns with the wrong drugs. And fortunately, in this case, we were able to find better mood management and good management of his pain control. So this was often labeled as addiction by the staff, but when in fact he was looking for management of mood. The second patient is a patient undergoing head and neck cancer, and we started giving him opioids to manage his pain and could not get it under control. We did learn that this gentleman had been abusing opioids, had been taking, prior to any medical condition, had been using prescription strength opioids, so he was highly tolerant to opioids, and that's why what we thought were effective doses were hardly even effective at all in relieving his pain, and that's why he also did not see any sedation as well. So this gentleman required very complex management and family meetings to address his issues of addiction, addiction management through psychiatry, and pain management that had to be done very, very carefully. We could not use oral management while he was hospitalized because of the head and neck cancer and the severe mucositis, but once the G-tube was placed, we could use transdermal and enteral administration of the drugs. And he did need higher doses of opioid because of his addiction, but we were able to do so in a safe manner and in a manner that wasn't replicating what he was doing on the outside. This last patient was 82 years old and became confused. He was on extended release morphine and then immediate release. And what we see often is patients who don't understand how to use PRN medications. And I do see it a little bit more often with the elderly, although there are no good data to support that. They've simply never had to take a medicine before when they quote unquote need it. And so they're so afraid of developing pain, they default to taking it however, with whatever duration we ordered for them, in this case 3 hours, because they're afraid the pain will come back. And in this particular patient, he didn't really need it every 3 hours, and he ended up becoming very sedated and somewhat confused. So this also was not a case of addiction, but rather a case where the patient didn't understand how to take his PRN medication. So I've shared with you 3 cases that I hope help to illustrate how this concept of safe administration in the face of addiction is really quite dependent upon adequate assessment and clearly understanding addiction versus other reasons for taking the medication. All of this is extraordinarily hard work. There are no easy, simple kinds of protocols or algorithms that can be applied in every single situation. So I wanted to share with you this quote from Margaret Mead: "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." So I welcome you to go out there and change the world for your patients, and Deb and I are happy to take any questions that you may have. Thank you so much for your attention.
Thank you very much for an informative presentation, both Drs. Gordon and Dr. Pace. I have a couple of questions that came in, but first I just want to do a quick public services announcement just to make sure that people are aware that SAMHSA has come out with an opioid overdose toolkit. And this is available at the SAMHSA website. It was published in August of 2013, and it's really to equip communities and local governments with materials to help prevent opioid-related overdoses and deaths. So I wanted to get that announcement in. One of the things that was mentioned was the take-back programs, and I wondered if you could provide just a little bit more information on that.
So there's a national take-back program that's held twice a year, and it's been held at least for the last 2 or 3 years. It might even be longer. If you just go to your browser and put in take-back programs or take-back opioid programs or take-back drug programs, you can get the dates. Actually, it's in April and in October. And on the website, you can plug in your zip code, and it will tell you where you can go. Sometimes it's a police office or a department. Sometimes it's a government organization. No questions asked. And this is not just for opioids, by the way. It's for any drug that you have that you clean out your cabinets and you want to get rid of. They incinerate the drugs. So the purpose of the take-back program was to decrease the effect of drug disposal on our environment. As you've probably heard, there are many situations where people are where communities are looking at their water supply and finding significant levels of antidepressants, hormones, and other byproducts of prescription drugs, not just opioids, by the way, but other kinds of drugs that people use for treating other medical conditions. And there's concern that that is reaching all of our bodies. And so the EPA offers this Take Back program, and then different communities have continuous take-back programs. As I mentioned, I live and work in Chicago. The Chicago Police Department partnered with the EPA, and there are designated police departments where you can bring a bag of drugs and no questions asked, they dispose of them.
Great. So let me just stay on that theme where programs or states are looking at preventing drugs from getting into the environment, whether it's through water or food supplies. And I wonder if you know of any states or programs that are doing some kind of statewide implementation programming. And you may not.
I'm really not aware of any statewide programs. I'm aware of the national program and then different municipalities. Deb, do you know?
I don't know of anything statewide, but one thing I'd like to just add to the discussion is the disposal of transdermal fentanyl patches. It is recommended that we do flush those when we're disposing them in the home. And I know a lot of people have questioned that issue of the plumbing and the amount of opioid that's getting into the water system from flushing unused transdermal fentanyl patches. And apparently the amount of opioid that's excreted in urine and feces by people taking opioids is much greater than the bit of waste that we do. So the idea is that you, unless you can directly incinerate them, you know, like as Judy's saying, bring them to someplace that will incinerate them, you need to get rid of them in a way that other people can't use them. You can't just throw them in the garbage because there is still a significant amount of fentanyl left in a patch even 3 days after use.
Great. When a patient is being discharged and recovery is expected over 2 to 3 weeks from a surgical procedure, do you recommend initiating a long-acting opioid to control pain with a PRN or to continue the IR opioids? For instance, we have a patient who is on 40 BID of OxyContin using 15 milligrams every 3 hours for breakthrough pain. We're debating on increasing her long-acting, but then on the flip side, she's not expected to require opioids for more than a few weeks.
Yeah, that's a great question. I don't think that there is a clear answer or good evidence to know what the best way to do it. I mean, for many years, we were really pushing the use of long-acting opioids, at least for several days after big operations. And even with chronic opioid therapy for chronic non-cancer pain, it may be that patients do better on short-acting PRN medicines than the combination of both. It really requires, I think, an individual assessment and look to see where the pain problem is. Certainly with acute pain, one would expect that within the first week it should decline fairly rapidly. So I would be more inclined personally now to look at use of short-acting medications and to kind of quickly drop the long-acting. It just kind of depends on, you know, patients' prior history of opioid use and their anxiety and their risk for developing physical withdrawal if it's abruptly reduced. We know when you were talking about state programs, I know the Washington state here has labor and industry guidelines that really says that you cannot prescribe opioids for longer than 6 weeks for acute pain. So that's usually the framework that we're saying is that we have to have some kind of plan that the patient understands that they should be off their opioids treated that were given for their surgery within 6 weeks. So I guess, acute pain is typically more something that you get with activity, it's a little more predictable, so I would think tapering the long-acting off fairly rapidly and then using the short-acting PRN as the person's recovering would probably be my thought.
And I think what you highlight is the importance of assessment, reassessment, reassessment, reassessment.
Absolutely, yep.
So we'll take one final question before we close. This comes from a kind of an anecdotal report from Mississippi. Anecdotally, a number of my surgical colleagues in Mississippi are observing considerable success managing post-op surgical pain with IV acetaminophen among patients with good liver function. Have you seen evidence-based data supporting these kind of anecdotal accounts?
Well, there's very good evidence that acetaminophen is a great non-opioid to give with an opioid for acute pain. So IV is not a different drug than oral. It just provides us the opportunity to give the drug to patients who are NPO, who can't take it. There is some nice evidence looking at the use of IV acetaminophen in terms of the timing of its administration. If it's given intraoperatively, I believe during some of the longer cases, it can actually help in terms of this nausea and vomiting and opioid-sparing effects. So yeah, Tylenol is a great drug. Acetaminophen is a great drug, but I think you have to just, choosing your route should be what's based on the patient needs, not that, it's better to give it IV versus oral.
Well, I want to draw to a conclusion because our time is up, and I want to thank everyone for participating in today's webinar. And again, thanks to our presenters for a really enlightening presentation. Shortly, our webinar participants will receive an email from the American Academy of Addiction Psychiatry that includes a link to an evaluation survey. We would ask you to take a few minutes to access it and provide your feedback on today's session. Today's webinar was recorded and will be posted on the website of the Physicians Clinical Support Opioid Therapies in the near future. That site is www.pcss-o.org, and a calendar of events and helpful clinical resources are there as well. All of this information can also be found on the INSA website at www.intnsa.org as well. And we do hope that you'll join us for upcoming sessions, all of which can be found on our website. Thank you and have a great and safe day.